The research article we chose to examine was called Group Therapy as a Social Context by Simone, Chiara, Kate, and Jess.
Our research article posed two clinical questions. One being, do participants with acute severe non-fluent aphasia initiate more frequent communication during group treatment than individual treatment, and what is the nature of those communication attempts? 2. Do other measures of communication skills, for example, yes or no question accuracy, number of different real words, and % accurate automatic speech differ between treatment settings?
This study looked at 10 participants with severe non-fluent or global aphasia following a left hemisphere stroke, all within 3 months post-onset in an acute care setting. They were observed during one individual therapy session and one group session at their stay in the facility. The comparison aspect focused on the patient's ability or willingness to initiate communication in the individual therapy session versus a group session. During the two intervention types, overall it was shown that individuals initiated communication more in the group settings, and we will talk about this more later in the presentation. This was a pilot within subjects' observational study. Each participant was observed during one individual speech session and during the augmentative communication group. 5 participants received individual treatment, then group therapy, and the other 5 received group therapy and then individual treatment. The observations were conducted between the 5th and 10th treatment days. The first SLP performed the therapy sessions without knowledge of the targets being measured in the study, and a second SLP observed the sessions and took data on the following measures: the number of participant-initiated communicative acts, the type, target, and purpose of each communication act. They also looked at the yes and no response accuracy, some automatic speech accuracy, aka counting 1 through 10, and number of different real words produced during the sessions. We categorized the key findings into a few different categories. The first one being aspects that changed positively. The participants initiated communication significantly more during group sessions. And during group treatment, there were different types of initiations, which led to varied communication opportunities. Additionally, there were aspects that did not change. The accuracy of yes and no responses and speech automatics remained the same during individual and group sessions. Lastly, the aspects that decreased were the participants produced fewer different real words during group therapy compared to individual sessions. But this could be due to the individual therapy sessions could have used more verbal communication, and group therapy may have allowed for more nonverbal communication. And the structure of the individual session may have been more constrained to structured naming tasks, and group therapy allowed for more natural conversational speech.
The overall strength of the evidence in this study is level 4 according to ASHA, or limited. The sample size of this study consists of 10 participants with severe non-fluent aphasia or global aphasia who are participating in an acute rehabilitation program. All participants were located at the same inpatient program, native English speakers, diagnosed with severe non-fluent aphasia or global aphasia, and had a left hemisphere stroke. The generalizability of this study's findings may be restricted due to the small sample size from the same acute rehabilitation facility. This study was designed as a pilot observational study. Since this study was an observational study, there was no control group. During the study, the researchers observed participants in one individual and one group therapy session. The group therapy sessions consisted of 2 to 6 patients, one of which was being observed for the research study in any group. The structured group sessions were intended to provide increased opportunities for the patients to interact with others. Participants were observed in their initial and group therapy sessions on the same day. One speech-language pathologist conducted the sessions, and she was unaware of the goals of this study to prevent bias in data collection. The researchers only observed the speech-language therapy sessions and did not provide any recommendations or standardized treatment for the participants. Since the study was strictly observational and no standardized treatment was provided, the results of this study may have limited generalizability. One SLP provided treatment to the study's participants, and the inter-rater reliability between the certified SLPs ranged from 0.90 to 0.99, depending on the task, which is very strong. Clinical expertise needed. Training, expertise, and knowledge about aphasia, specifically prognosis, diagnosis, and treatment approaches, is important to understand and interpret this study's observations. Clinical judgment is required to interpret the results regarding the amount of conversational initiations within group and individual therapy delivery models, and conduct more research regarding evidence-based treatment methods for aphasia before implementing interventions with patients. Clinical settings capable of accommodating group therapy interventions, adequate time to allow all group therapy members the opportunity for conversational practice, and clinical expertise in the area of group therapy for patients with severe aphasia could be constraints to implementing group therapy as an intervention approach for patients with aphasia due to a stroke.
In terms of clinical implications, this study suggests that group therapy should be used in addition to individual therapy, not as a replacement, especially in early post-stroke rehabilitation for individuals with severe aphasia. The findings indicate that group settings may be better to support functional and pragmatic communication goals. This is reflected in increased communication, initiation, and more socially driven interactions among participants. Group therapy also creates meaningful opportunities for peer-to-peer communication. This can enhance social engagement and reduce the isolation that is commonly experienced after stroke. Another important point is the use of multiple expressive modalities in group settings, such as gestures, facial expressions, and vocalizations. This is particularly beneficial for individuals with limited verbal output, as it allows for them to communicate more effectively in different ways. Overall, these outcomes align with participation-based goals and may contribute to improved quality of life, even though quality of life was not directly measured in this study. Finally, it is important for clinicians to consider individual client factors such as preferences, confidence, fatigue, and tolerance for group interaction when determining whether group therapy is appropriate. There are several limitations to keep in mind when interpreting these findings. First, the study used a small sample size of only 10 participants, which limits the ability to generalize the results to broader aphasia populations. Additionally, the study used an observational design, meaning that treatment activities were not controlled. Because of this, it is difficult to determine whether the differences observed were due to the therapy setting itself or the nature of the tasks, such as structured activities versus more conversational interactions. While fewer real words were produced in group therapy, this does not necessarily indicate reduced effectiveness. Instead, it may reflect differences in the communication context, such as increased use of nonverbal modalities in group settings. Another limitation is the study focused on the quantity of communication rather than the quality or functional effectiveness of verbal output. There was also no standardized score outcome measures used, such as formal aphasia assessments or quality of life scales, so the broader clinical impact is inferred rather directly measured. Finally, the applicability of these findings is limited due to individuals with acute, severe, non-fluent aphasia. Individuals with mild, fluent, or chronic aphasia, as well as those with significant comorbidities, were not included in this study, which further limits generalization.
When reflecting on this study, we found that the increase in communicative initiations during group therapy compared to individual therapy was the most straightforward finding to interpret. This was further supported by quantitative data showing consistent patterns across participants during group therapy. Also, Minimal interpretation was required due to the comparison of the data between the two settings. It was challenging to determine the purpose of communication from the participants due to subjective intent, making it unclear whether they were commenting, trying to connect socially, or just responding automatically. As a result, the responses were recorded as unidentifiable. For future clinical practice, it should be known that adults with aphasia are more likely to initiate conversation in social settings. It is important to consider designing group therapy sessions based on functional communication rather than strictly creating drill or naming procedures.